Good morning, respected chairpersons and dear respected ladies and gentlemen. Well, chest pain still, as of today, remains a big diagnostic dilemma. Over the years, there has been a rapid progress in cardiology, in the field of medicine. We have come a long way from the initial investigations, treatment, and diagnostics such as ECG to the latest CT scans and huge armamentarium in our field, but still the accurate diagnosis and initial treatment still remains a dilemma. We know that up to 25% of emergency department visits are due to chest pain in some or the other form. And just to take you straight away, the chest pain broadly we classify into visceral and somatic chest pains. The visceral chest pains are usually referred like aching, heaviness, discomfort, and they are difficult to localize. Somatic are sharp and easily localized chest pains. When we talk of chest pain, we are talking of acute setting. We are not talking of a long-term chest pain. We are discussing of an acute setting, which means sudden or a recent onset, which means that usually within minutes to hours, and presenting typically less than 24 hours. And when we say chest, we mean thorax, mid-axillary to mid-axillary line, xiphoid to suprasternal notch. And pain is a noxious, uncomfortable sensation. We can also describe it as a ache or a discomfort. Now, whenever a patient comes with a chest pain, we are initially trying to find out his basic hemodynamics, trying to know what is his pulse, blood pressure, whether there is dyspnea, whether he needs an IV line, oxygen, monitor or an ECG. This is the basic protocol which we follow in the ECG. Now, in our emergency department, whenever a patient with a chest pain comes, the initial evaluation has to be followed as an acute emergency, and we must look for the airway, breathing, circulation, vital signs, and then also do a focused examination with the cardiac, pulmonary and the vascular systems. Now, one of the very important classical hallmarks of chest pain is an accurate history. The diagnostics are also important, but the history is very important, which we call as a typical or an atypical chest pain. We distinguish it as a typical or atypical chest pain, and when on the historical basis we make the diagnosis of a typical chest pain, the chances of a cardiac pain increase. We must take into account the character of pain, the presence of associated symptoms, history of cardiopulmonary disease earlier, and the intensity of pain. On examination, the quality, radiation, migration of pain, severity, onset, duration, frequency, progression, the provoking or relieving factors can play a vital role. For example, if a patient comes with chest pain and we examine and find a local tenderness or pain on movement, we can straight away rule out a big chunk and unnecessarily do not subject such a patient to tests such as cardiac troponins, the other diagnostic tests, and even the angiograms. So they all can be ruled out just on the basis of history. History is a vital hallmark. Then the associated risk factors. For example, if the patient has got a strong family history, diabetes, hypertension, they are very high risk, likelihood of having a cardiac disease increases. The physical examination also plays an important role. Then one thing which I would also like to emphasize is a role of old records. We must insist that patients, if they have chest pain and if they have old ECG, they should bring it to the hospital. Just one old ECG and comparing with the new one and having fresh changes can make a lot of difference. We can come to know whether it's a new change or an earlier change. Just to categorize various chest pains, we describe it as a chest wall pain, pleuritic or respiratory pain, or a visceral pain. As I told about the chest pain and the visceral pain, the pleuritic or a respiratory chest pain usually is sharp somatic pain and would increase or vary with breathing or coughing. So many times a patient comes to the emergency and says there is a left side chest pain, but this pain increases whenever patient coughs or on deep inspiration, so it's a pleuritic pain. These are the usual causes of the chest pain. It could be because of chest wall, it could be because of pleura, which could be because of pneumonia, embolism, pneumothorax, associated pericarditis or a pleurisy. The visceral pain can also cause similar, such as a chest pain kind of a situation. And the most important pains are the pains of cardiac origin, which are very important. Now, they are not sharply localized pain. Another rule of thumb which we were taught in our medical college was, if the patient is able to pinpoint with the finger a particular point, then it's very unlikely to be a visceral pain. It's very unlikely to be a cardiac pain. These simple examination and historical techniques can help us differentiate. The visceral pains which are of importance can be of cardiac origin, like angina, myocardial infarction, aortic dissection, pericarditis. It could also be because of esophageal reflux, rupture, or a mitral valve prolapse. I would just like to highlight the broad differential diagnosis of chest pains. Now, according to the frequency, we can broadly classify them as angina, myocardial infarction, other cardiovascular diseases, pulmonary or pleurisy, GI, musculoskeletal, and psychogenic. Now, this is another very important cause of chest pain, in which we see so many times young people coming with lot of stress, presenting as chest pain in the emergency, having atypical ECG changes, and being investigated. Now, just to highlight, what is angina? Angina can be typical, atypical, it can be chronic, stable, unstable, and a variant angina. Usually, typically, it has an onset with an exercise, with cold weather, with emotional stress, and usual location is retrosternal. The radiation of pain can be in the jaw, neck, epigastrium, shoulder, or arm. I would like to highlight one very important feature. We see very commonly unusual presentation of chest pains. We see patients coming with myocardial infarction, visiting dentists for tooth pain for days together, and suddenly collapsing. And when they come to the emergency, do the ECG, they have acute infarctions. We have had so many patients coming with pain in the shoulder. We have also had patients coming with pain in the fingertip, just in the fingertip. So it's important not to miss such patients and go into a little bit detail in the history. The character of typical angina pain is heaviness, squeezing. Duration is usually 2 to 10 minutes. Any pain lasting for a very long time is very unlikely to be angina pain. And usually it is aggravated by exercise, emotional stress or something, and relieved by rest or sublingual sorbitrate. Unstable angina is one which occurs on mild exertion, which is of new onset and usually is of crescendo type. Well, this is the usual etiopathogenesis, and at rest, as we see, where there could be no ECG changes, and as the patient exercises, there could be ECG changes in the form of ST segment depression, and this is seen on the coronary angiogram as obstruction in the coronary artery, if we correlate this with the coronary angiogram. Now, going to myocardial infarction, which is the life-threatening complication, the pain quality is similar to that of angina, but is of more severe and of a longer duration. And on the ECG, if we find a new onset left bundle branch block or an ST segment elevation, then it could be a myocardial infarction. Now, this is an emergency situation. We need to rush these patients earlier for treatment, because we all know that time is muscle. If we waste time, we are preventing the patient from further, we are trying to prevent further complications if we treat them early. Such patients need to be taken up early to the cath lab, and their arteries need to be opened if they go for the percutaneous PCI interventions, or we need to give them early thrombolysis. These are the classical changes which we see with myocardial infarction, which are the ST elevation. These are the early changes. Sometimes patients come to us having chest pain for a couple of days, and then when we do the ECG, they have already evolving changes, which are usually the ST segment starts to settle down with the onset of a Q wave. The cardiac enzymes also help us in distinguishing patients with chest pain, and we should not hesitate to use troponin, CPK, CPK-MB levels. The other ischemic-like chest pain could be because of aortic stenosis, hypertrophic obstructive cardiomyopathy, severe systemic hypertension, right ventricular hypertension, aortic regurgitation, severe anemia, and hypoxia. The non-ischemic cardiovascular region of chest pain can be because of aortic dissection, pericarditis, and MVP. A word about aortic dissection: it is a sudden severe onset of pain, tearing and sharp, and usually confused with other kind of cardiac pains. Now, one hallmark in examination which I would like to point out is pulse asymmetry. When we look for pulse, it is very important to look for the peripheral pulses. And if we find that the pulses are asymmetrical, they are very likely to be having aortic dissection. And if we do an X-ray, we might find broadening of the mediastinum due to dissection, and the CT scan can be diagnostic for such kind of a pain. For pericarditis, usually it's a deep pain, and usually such pain is associated with pruritus and would aggravate due to breathing. And on examination, there would be a frictional rub. Now, the ECG of acute pericarditis sometimes it can be confused with acute myocardial infarction, because this also has ST segment changes such as ST segment elevation, but the hallmark is you don't find any reciprocal changes in the form of ST segment depression or new Q waves on evolution. Pulmonary embolism can also present with so many symptoms like dyspnea, increased respiratory rate, increased heart rate, chest pain, cough and syncope. We should keep this in mind, and sometimes such patients are being treated as acute coronary syndrome. There can be very subtle ECG changes. We find pulmonary embolism pain, and such patients might have even a normal ECG and X-ray. Elevated D dimer or a CT scan can really help us in going into in clarifying the picture. The gastrointestinal diseases such as esophageal spasm, reflux and peptic ulcer disease can also cause pain. Neuromuscular skeletal disorders like herpes zoster, degenerative disorders and costochondritis are other common causes of chest pain. Now, various kind of pains can manifest in the various areas. Just to summarize, the objective of this talk is that we sharpen our skills, the diagnostic skill. We should broaden the differential diagnosis. Do not stick with one prefix idea in our mind. We should also keep into account the family history, social history and the past medical history, and also keep the vitals in account while whenever examining such a patient. And a relation of pain to movement, relief by antacid and local tenderness. These are very important in the examination part. As far as the diagnostic testing is concerned, we should, if we do the ECG, it can help us in picking up early ischemic symptoms and ischemic kind of a chest pain, but a normal ECG does not rule out that a person is not having any cardiac event. The major diagnostic pitfalls which we should not forget is, and we should always keep in mind whenever a patient of chest pain comes, is as far as cardiac pain is concerned, is acute myocardial infarction or acute coronary syndrome, aortic dissection, pulmonary embolism, pneumothorax, pericarditis or a esophageal rupture.
I think you can summarize it.
Yeah. Just to summarize, whenever we are thinking of chest pain and on physical, we have done the physical examination and history, we should avoid the pitfalls, avoid narrowing the differential diagnosis prematurely. Do not go with a preformed idea that this patient cannot have a cardiac pain. We should reassess the patient, repeat the study, repeat the ECG at regular intervals, have a close look at the chest X-ray, should not miss features like pleuritis, pneumonia, aortic dissection. And I would like that we should remember the same differential diagnosis whenever we are keeping the patient of chest pain in the emergency. We all get our fingers burned now and then, which the diagnosis of chest pain, and I think all of us must have had our share. The patients coming with chest pain not being diagnosed properly, ultimately having myocardial infarction. Now, one thing I'm really worried about, and I talk about it every day, is the syndrome of gas in our kind of society. Most of the people would come to us and would say that they get gas, and the gas could be such as coming on exertion or something. Now, such are the patients who are really at a high risk. I would like to highlight this, that patients do not die of heart attacks, usually they die of gas, because if they think it's a cardiac pain, they would rush to a doctor and get treated, they would get well. All cardiac diseases can be treated, get well, but unfortunately, when we do not think it's a cardiac pain, it's something else, we land up in soup and problems. Thank you very much.